Hey, good morning, everyone, and thank you for joining our webinar today on tobacco use, identification, intervention, and referral. So this webinar is part of an ongoing public health and primary care series featuring public health experts offering valuable training and resources to primary care providers, along with ideas and examples of how the two can work together to improve population health. And we are very excited to be with you. So I'm Rebecca Valley with QCOR and the Patient Centered Primary Care Institute. So before I turn things over to our presenters, I just want to review a few things about the technology we're using today. Since we have so many of you on the line, everyone is and will remain on a global mute throughout the presentations. However, we do have plenty of time set aside at the end to take your questions, and we welcome you to submit your questions via the question pane on your control panel. You can type away and I'll read your questions for any of the presenters to answer, but don't feel like you have to wait till the end to ask your question, so you can enter those at any time. If your question is for a specific presenter, please note that. And also feel free to send me any messages via the question pane if you're having technical issues, and I'll do my best to assist you. One question that we do always get is about accessing the slides, and yes, we will send all webinar participants a link to the recording along with the PowerPoint slides and any additional materials after the webinar. And then just a few words about the Patient Centered Primary Care Institute. So the Institute is a public-private partnership that was launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation. It is currently managed by QCOR. Together with the experts that we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards a patient-centered primary care home or medical home model of care. We work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to visit our website at www.pcpci.org to access resources, including previous webinars. You can sign up for our email list on the website, which is how we announce additional web-based and in-person training opportunities, as well as future Institute programs. And as I mentioned, the Institute aims to help primary care practices achieve recognition as a primary care home through Oregon's Patient-Centered Primary Care Home Program, PCPCH. The model is a set of standards organized under 6 core attributes, which you see here. And you can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. So without further ado, I'd like to introduce our wonderful panel of presenters this morning. First, we have Scott Montagna. Scott is the Health Systems Coordinator for the Health Promotion and Chronic Disease Prevention HIPCDIP section at Oregon Health Authority's Public Health Division. He provides strategic direction for HIPCDIP health system-related efforts, including for the Tobacco Prevention and Education Program, which addresses tobacco use through coordinated programs and partnerships, and allegiance to rigorous, data-driven, and evidence-based practice. Scott has worked in public health for nearly 10 years in Oregon, Texas, and throughout Central America. Welcome, Scott. And then we have also on the line Sylvia Ness, the Community Health Worker Program Supervisor at Multnomah County Health Department. Sylvia has been involved in public health efforts since 1998. She's worked in training and curriculum development, supply chain management of health commodities, commodity security for family planning products, vaccination and health mobilization campaigns, disease prevention and health promotion, and primary care strategies for patient engagement and learning. She's also worked in 11 different countries throughout Africa and Asia. Sylvia joined the Multnomah County Health Department 5 years ago and has focused on implementing group visits and work around patient self-management, such as the referral to the Oregon Quit Line. Most recently, Sylvia's work has focused on growing a successful community health worker program. Welcome, Sylvia. And then finally, we also have with us today Deborah Sabatnik, Operations Program Specialist at Multnomah County Health Department. Deborah has worked for the Multnomah County Health Department since 2006. Her work within the healthcare and healthcare as a referrals coordinator, program specialist, and most recently as an operations program specialist informs her interest and appreciation for working with diverse and underserved populations. Her most recent work involves collaborating with internal and external partners to develop data and EHR systems that support the objectives of healthcare transformation. Deborah's work focuses on innovative and evidence-based approaches to health and wellness with the goal to more fully engage patients in their own experience of care. Welcome, Deborah, and welcome to our wonderful panel of speakers. But without further ado, I'd love to turn it over to their capable hands. So Scott, it's all yours.
Great, thank you. Good morning, everyone. It's really great to be here. As Marissa mentioned, I'm Scott Montaigne I'm the Health Business Coordinator for the Health Promotion and Chronic Disease Prevention section at the Public Health Division. I'm very excited to be here this morning with Sylvia and Deborah from Multnomah County Health Department, who will share with us some lessons learned from their work in developing and implementing a tobacco cessation referral workflow. I'm going to start off this webinar by sharing some background information on the Oregon Tobacco Quit Line, which is a cessation service offered by the state to all Oregon residents. I imagine most of you listening to this webinar have or are familiar somewhat with the Quit Line, though I think there's some new information that I can share with you today, specifically around a new online referral tool that we launched last month, as well as I want to highlight some of the elements of each coaching call that our coaches use to support participants with their goals and their needs. So we know people want to quit. In fact, the latest behavioral risk factor surveillance system data, which is known as BRFIS, shows that almost 80% of tobacco users want to quit. Most tobacco users cite health concerns as their #1 reason. This includes chronic conditions that patients are trying to manage, as well as asymptomatic patients who are concerned with potential health problems down the road. Another common motivator is children. Social stigma is another one, and the financial burden of tobacco is another reason people want to quit. The good news is, though, we know what works. We have well-documented tobacco strategies that prevent initiation by tobacco by young people and effectively support current tobacco users in their quit attempts. And so the Oregon Tobacco Quit Line is just one piece of a much broader comprehensive tobacco prevention and cessation program that the Public Health Division supports. And although most tobacco users want to quit, as I mentioned, 80%, few adults are ready to quit in the next 30 days. However, there are several brief interventions that have shown to be effective in helping people quit tobacco, and the two that are probably most well known is the 2 A's and an R and the 5 A's. The 5 A's approach to smoking cessation is based on key elements of cessation interventions as determined by the Public Health Service Committee through their review of cessation methods. They did a meta-analysis, they looked at existing data, and found that counseling and medication were the most effective interventions to improve cessation rates, and that both worked better than either alone, so in combination. Further, they found that advice from physicians improved adult cessation rates, and when that advice turned into brief counseling, it increased cessation rates even more. So as a result, the U.S. Public Health Service guidelines were published recommending that clinicians routinely deliver a brief 5-step intervention, and this includes asking about their tobacco use at every visit, advising all tobacco users to quit, assessing their readiness to make a quit attempt, assisting the patient in their quit attempt, and then finally, the last day, arranging for follow-up contact to support those efforts. And the 2 A's and an R, it's similar to the 5 A's, but it is an abbreviated intervention that remains consistent with the Public Health Service guidelines, but it's something that health workers, physicians can do in much less time. There are also other variations to these models. You may have heard the 3 A's, the 5 R's, whatever model you choose to use or individual elements that you borrow from those models as you engage with tobacco users. We know just by asking about tobacco use and then supporting the patient with cessation resources, particularly if those resources are counseling or medication, we see higher cessation rates than tobacco users who do not have that interaction with a healthcare worker and the follow-up support. So the Quit line was launched in 1998. It was in the early 1990s that research demonstrated that telephone-based counseling for tobacco cessation was an effective treatment. California was the first state to offer this service, followed by Massachusetts, Arizona, and then Oregon was the fourth state. Today we see the Quit line offered in all 50 states. It's also in DC, Puerto Rico, Guam, all 10 Canadian provinces, and recently it was launched in Mexico. So the Quit line is really a service that is available to all individuals throughout North America. It's coordinated by the Tobacco Prevention and Education Program, also known by its acronym TPEP, which is where I work in the Public Health Division in the Oregon Health Authority. And we contract out the service with a company known as Lear Wellbeing. And Lear operates Quit lines in 29 states, and they provide services to more than 700 employers and health plans across the U.S. And they've been our Quit line contractor ever since the beginning, 1998. So there are a couple ways to access services from the Quit line, either by calling one of the numbers listed, 1-800-QUIT-NOW, or we have the Spanish number as well, or registering online. And the web-only option is a standalone option. So if a participant doesn't want to talk to anybody on the phone, they can do everything via this website here, quitnow.net /Oregon. With that said, there is a nicotine replacement therapy dosing call that occurs, and that dosing call is just general information around safe NRT use. However, if that individual doesn't want to take that call, then they can simply put 000 in the phone number field, and that will avoid a call being generated by the Quit line to them. So once a patient is connected to the Quit line, the process for accessing support is quite simple. The tobacco user will register with an enrollment staff, and then immediately will be transferred to a Quit coach for assessment and planning. The Quit coach incorporates motivational interviewing techniques, problem solving, coping skills, and then they help create a personalized Quit plan for that patient. Following that call, the Quit line then will mail nicotine replacement therapy, and that can be either the patch or the gum or a combination of both. And then they also send some printed material such as a Quit guide to support with their Quit attempt. So Quit line coaching sessions, it's grounded in social cognitive theory, and social cognitive theory is one of the few theoretical models for health behavior change that incorporates not only the individual behaviors, but also the biological and environmental factors, which clearly plays a role in tobacco addiction and cessation. Each coaching call, it's structured, but it's not scripted. So it addresses the environmental, personal, and behavioral domains of social cognitive theory. And this approach allows coaches to respond to each individual's needs as the call unfolds. Also, it ensures that they follow an intervention with logical steps that explores the participant's goals and then sets a concrete plan. So each call contains 3 phases. The first phase, the exploration phase, includes a thorough assessment to fully understand where the participant is at the time of their Quit process, including a comprehensive assessment of tobacco use and their Quit history. We know that typically when someone is calling the Quit line, it's not their first Quit attempt or their second Quit attempt. Likely it's their 4th, 5th, or 6th, or even more. The second phase is the insight phase. That's where the Quit coach interprets the assessment information and identifies both the strengths and the challenges that the participant faces. And then finally, the last phase is the planning phase. And that's where the Quit coach works collaboratively with the participant to create a sustainable and realistic plan based on the insight that they were able to glean during the exploration phase of the call and is consistent with the scientific evidence. So there's really only 3 criteria to be eligible for the quit line. The first one is you must be 13 years to enroll in counseling and at least 18 years of age to receive nicotine replacement therapy. You must live in Oregon, and if you don't live in Oregon, whatever state you reside in, again, there's a quit line service there. And then finally, you must be ready to set a quit date in the next 30 days. So there is a wealth of evidence from research over the last 25 years that demonstrates that quit lines are effective evidence-based treatments for cessation. So for example, based on numerous clinical trials and meta-analyses from the Public Health Service, as published in their clinical practice guidelines, they concluded that after 6 months, 28% of patients who used counseling and medication were tobacco-free. And that's compared to about 23% who only use medication, less than 13% who only receive counseling, and about 8.5% who receive no counseling or medication. So we know the chances of quitting increase greatly if you're receiving that support of counseling and medication, up to 2 to 3 times as likely as someone who does not receive those support services. There are a couple ways people get connected to the quit line. Some hear about the quit line from an advertisement. They see a brochure. We had a pretty robust media campaign last winter. It spiked calls to the quit line quite dramatically. Actually, we received about twice as many calls during that period. The other way, though, that individuals get connected to the quit line is from referrals from a healthcare provider. If the tobacco user is interested in quitting, they complete a fax referral form with the provider or another support staff, and then that clinic faxes the form to the quit line. This generates an outbound call from the quit line to the patient, and they'll make multiple attempts over the next several days to try to enroll them and provide the available counseling services. So using a fax referral form, it's great for healthcare providers as it provides a quick and easy way to direct patients to a service and support them in their quit attempt. And it also relieves the patient of having to face that barrier of initiating the first call to the quit line. And here is a link where you can download the fax referral form from the Public Health Service website. We have the forms both in English and in Spanish. And as I mentioned when I first started off this call, we launched last month an online referral tool. It's similar to the fax referral as far as the information that you're going to provide. However, it's on the Oregon, the quitnow.net/Oregon website, and allows a clinic or a social service agency that doesn't have a fax machine, or maybe a community health worker who's working out in the field, to send a referral using their computer or their smartphone or a tablet. So on the bottom of the slide here, you see a button that says Refer a Patient. That's the button that you're going to click, and it'll take you to this next page, which you can only see the top of this web page. But if you looked at a fax referral form and you looked at this web page, it's very similar fields. If your clinic has ever sent a fax to the quit line, your clinic information can be found in this drop-down menu. So you'll just click in that pink or orangish box right there, find your clinic, and then the first 4 fields where it's the clinic name, phone number, fax number, and the county will be pre-populated. And then you'll go down and just check if you're a HIPAA-covered entity, and then if you scroll down on this page, you would see the patient's information and all the other information that we collect on the fax referral form. And then you just say click, and it sends a referral to the quit line, and that generates very similar to the fax referral, an outbound call to the patient to enroll them in the services. So electronic referrals, that's when a health system or a clinic provides an electronic file of the patient or a health plan member to the quit line. These patients have been identified through their EHR or EMR as tobacco users who are interested in quitting, and that file is sent to the quit line, and then again, there is an outbound call that is generated to the patient. This is kind of the wave of the future. We're seeing more and more clinics and health systems across the country integrate referrals to the quit line in their EHRs, and I expect in the coming years in Oregon we'll see much more of that as well. And finally, closing the loop on the referral, we know a lot of providers, healthcare workers, they're interested in knowing the progress of their patients after they refer them to a service, whether it's a self-management service or whether it's the quit line. If you indicate on a fax referral form or on that online referral tool that you are HIPAA covered, the Oregon Tobacco quit line will fax back information on the individual patient. So whether they were reached, did they enroll in counseling services, and then that information can be uploaded to the patient's medical records. The report includes the patient's information, the status, so whether they either accepted or declined services, and then their planned quit date. So the provider can follow up and see if they're on track with their cessation attempt on that planned quit date. So that's all I have to share with you today around the quit line. I know when they send out the slides, our contact information will be included. So if you have any questions around the fax referral form, the online tool, e-referrals, please send me an email or give me a call. Quick note, the online referral tool, we are updating some of the language to be more inclusive of other referring entities, those social service organizations or nonprofits who want to make referrals. So some of the language will change around clinic and provider, but it works as is, and the changes that we'll make won't be changing the fields. It will just be changing a little bit of the language. We should do that upgrade in the next week or so.
Good morning, everyone. Thank you all for coming out first thing on a Wednesday morning. My name is Sylvia Ness, and I will be co-presenting this morning with my colleague Deborah Sabatnik. And we're really going to be talking today about a quit line referral that we implemented about 2 years ago. And specifically, we're going to be talking about some of the best practices as well as the lessons learned from implementing that referral. If you don't know the Multnomah County system, we have 8 different primary care clinics. We work in the Integrated Services Division of the County Health Department, and those 8 different clinics are federally qualified health centers. Deborah did some work at one of the clinics, some quality information work that really dived deeply into this referral, and so she is going to be using some of that work as kind of a mini case study so that we can look at one of our clinics a little bit more in depth. So one of the things that we did, you may or may not be able to see this. I know the referral is quite small in the slide, but along the left-hand side of that actual referral workflow, there are several different categories of people who are involved in the workflow. And so one of the first things that we did when we were developing the referral was to involve all of those different people in the development. We wanted to make sure that this referral really mirrored the other referrals in our system so that it would be easy and quick for people to do. And this was something that we found to be really essential part of this work, to have everyone that was actually involved in the referral also involved in putting together the workflow. The second thing that we did is that we vetted this with our leadership as well as with the lead providers and managers, since they're the ones who really would be rolling it out. So one of the things we discovered, though, even though we spent all of this time investing in this lovely, colorful workflow, is that it isn't enough to have a great workflow. Really what you need to have is you need to have something behind it that motivates people to care. One of the reasons that we went to this work in the first place is that we had meaningful youth pushing us in a way to make this workflow make the referral a reality. And where we kind of started out in that direction, but we pretty quickly realized that if people don't have the what's in it for me piece of this, that they don't really care very much. It's not that they don't care about doing it, but in their very busy day, it makes it harder and harder to have this workflow actually happen. So we had a lot of discussions about the importance of actually referring people. Some of those numbers that Scott shared earlier, the 80%, really looking at the evidence around if a provider or if other members of the health team are involved in making the referral, how much of a difference that actually makes to someone actually quitting. And so having that kind of evidence and sharing it with people on your staff and talking through their importance in the process became a really part of that motivating people to care. We also realized that you need a training plan. Oftentimes in bigger systems, we will roll out a workflow, but you also need to take some time to sit with people to make sure they understand all of the elements of that workflow and to actually have a plan to roll it out to each of your different clinics, to each of the teams at those clinics. And finally, that follow-up on training piece, and Deborah will probably talk a little bit about that piece. I mean, if you don't have, people will have questions. They'll start out doing the referral, and they'll get halfway through the process, and then they'll realize they have a question. So it's really essential to have people on site who can provide that kind of elbow support and answer questions when they come up for people.
So to that end, when I was looking at the work, doing that case study within my clinic, I started noticing that the referral numbers were a lot higher than what was reflected in our numbers of the people that were getting trained, referred to or counseled in smoking. So when I started looking at the workflow that the provider or the support staff was doing, we realized that they were doing all the work, but they weren't clicking the button on the electronic health record, which is what Meaningful Use uses in order to get the credit, for us to get the credit for that. So that tiny little step that nobody had thought of up until that moment had been left out of creating this great workflow. We didn't have the actual practice in place. And so as soon as we found that out, we added that to the workflow. And here what you can see is a lot of people started doing the screening for the tobacco cessation, but the counseling was not coupled with that. You can see in the blue, that's the number of patients that were getting screened, but in the red is the number of people that were being counseled. And that really translated, when you look at the, when you look at the referrals made, you can see a lot of referrals were being made, but then when we got the report back from the quit line, which is the next slide, you'll see that even though the referrals were being made, the people that were accepting the services weren't necessarily matching the referrals. And what I think that showed is that if the when I did the deeper dive and I started looking, okay, what is happening here? Why are some providers doing so many referrals but are having such little accepted services? You can see in provider D right there, huge number of referrals, very little accepted services. What that translated to was the common theme along that was counseling. If they actually put in the note that the counseling was given and a discussion was had between the provider and the client, that is what seemed to make the difference. Provider A had, and provider E, they had the highest number of referrals, the higher number of acceptance. So that was the key point for us.
And along the lines of the counseling, something that we found that was really important and that ended up being a missing step for some of those clients is figuring out at what stage of readiness people really were and before they were referred to the quit line. As Scott mentioned, in order to refer someone to the quit line, one of those category of criteria are that someone needs to be ready to actually make a quit attempt within 30 days. And so that was an area that we were really falling down in. We were making lots of referrals, but we weren't necessarily referring the right people. And moreover, we weren't referring people who were at the right readiness. And so we've really taken a step back, and I think that that's why people who did the counseling were much more successful, because they were really evaluating this readiness piece. So we don't want people who are in that pre-contemplative stage. They aren't yet ready, and it could really result in a situation like the one that Deborah described, where they get a referral to the quit line, they're not ready, so they basically get kicked right back out. And we're emphasizing this because it ends up being, in some ways, a real waste of people's time. If you're referring people who are not yet ready, it's a waste of their time, it's a waste of the quit line's time. So this is something just to think about on your end in a clinical system, is making sure that you also have a counseling piece in place so that you're getting those people at the right stages of readiness, people who are prepared, who are ready to take action. Another thing that we realized from going through this process is that this is really an ongoing conversation with people. Scott talked about the fact that oftentimes when they get to the quit line, this is already someone's fourth or fifth or maybe sixth or seventh attempt. So people, it takes them a long time to go through this process, and it's important to realize our part in that process, and that we don't look at this as a referral that we make once or a conversation that we have once. This is something that should happen really at about every visit, depending how frequently your client is coming into the clinic. And we are thinking about it kind of along the lines that we would think of a chronic condition like diabetes. So you wouldn't talk to someone, one of your clients with diabetes, about diabetes once. You talk to them every single time they come in. How is this going for you? What's changed since last time? What successes have you had? So we treat it really in the same manner as a conversation like that. We've also found that it's important that our clients don't just have this conversation from one source. For some people, that trusted source is their provider, and I think that's really borne out in the evidence that Scott talked about. For some people, however, we've really seen a phenomenon where they'll say yes to their provider around the referral because they want to please the provider. So it might be someone else on the health team who is able to have a little bit more success in that area. It won't be the provider for everyone. Maybe for someone else it's the medical assistant, maybe it's a team clerical assistant, maybe it's a nurse, maybe it is a community health worker. So that it's really important to get many members of your team involved in this conversation and to help them realize how important they can be in this conversation, that this is not just something that the provider needs to talk about. So I want to highlight now one of the elements that we have taken on as a best practice. Part of our referral system, we also came up with an education component. And this is part of the education component that we came up with. It's a series of tobacco cessation screensavers. So this is just one of them. These screensavers show up in the exam room. So if a client is spending any time waiting, either prior to meeting with the medical assistant or their provider, these screensavers will pop up, and they have a variety of different messages around tobacco cessation. So this is just one of the ways, outside of that actual counseling, that we keep the conversation going. Some of our MAs actually use this as the discussion starter. So they are required to do a screening around tobacco use, and one of our MAs, for example, uses this as the way to ease into that screening question, into that conversation. So she'll say something like, you know, you saw those screensavers when you sat down in here. What did you think about those? And then she'll ease into the conversation from there. Most people do have an opinion about what they saw, whether even it doesn't matter whether they actually are using tobacco or not. Pretty much everyone knows someone that they care about that uses tobacco. And so sometimes it starts a conversation about a loved one or someone important in their life.
So one of the other things that we found out is we were doing the faxing, the paper referral form, and people were just printing them out, having the patient sign their consent, putting in the right time that they wanted to be contacted, and sending it off. And we started getting a lot of responses that the patients were unreachable. We started realizing that we needed to confirm the phone number. Something as simple as that step was getting missed. You assume that maybe at the front desk this is happening and it would update the record in the back, but it was not always happening. We started finding that the more we confirmed the phone number at every point of the conversation, we started finding, oh, okay, you do have a different number. Sometimes what happens at the front desk, they'll say, are you at the same phone number? The client will say yes. Nothing gets checked until it gets brought to the back. You print it out and you show them this phone number and say, hey, is this the number? And then they said, oh, no, I've actually changed it since the last time I was here. So a simple step such as that can make a huge difference. The other thing that we found in our initial work is that we didn't have a really good way of closing the loop of that referral. We would get the report back from the quit line, but we didn't have a way to track it within our system. So we came up with a way that we were able to track the referrals just like we did any other referral if they went to get an MRI or anything like that. In doing that work, we actually found that we weren't getting all of the reports back from the quit line necessarily. So as soon as we contacted them and started working with them, they were really helpful to work with, and they came back with some reports, and we were able to find those reports after all. But that was a key part of the referral process as well, because sometimes if we got the message that the patient was unreachable, we were able to contact them, update the phone number, and maybe update that referral. Or if the patient was not ready to quit, we would note that in the chart so that the next time the client came in to see the provider, the nurse, whomever, that conversation could get started again.
One of the things that we were also able to do in working with the quit line was to actually change the time period in which the calls are made. We found with our client population, people who often have cell phones that they pay them in advance and then are unable to pay them for a certain period, and then the quit line was having a really hard time contacting them during that period when their phone wasn't turned on. So we worked with them to talk about having a shorter time period than 1 month, where we would actually be, so sometimes the time period for us that we were getting the reports back was shorter than 1 month, and so we were working with them to get something that would be a little bit more appropriate for our population. And we found the quit line, as Deborah mentioned, was exceedingly helpful in accommodating us and in working with us to make something that would work for our population. We also actually worked with them to have them review their lists and contact people that couldn't be reached every quarter. So again, this issue of if there's someone that for whatever reason their phone went out of use and they weren't able to get the call, the quit line now is actually going back each quarter and reviewing those unreached people and trying to reach out to them again. So there's a little bit of a safety net that we've built into our system in the hopes that that will catch some of those people who they were not able to reach initially. And then finally, we just want to summarize some of the lessons learned. So firstly, our recommendation is definitely to develop a toolkit with staff representation to make sure that training and coaching as well are highly prioritized and that you're really focusing on what's in it for all of us. Including the whole team in conversation about tobacco use, so not just the provider, but having those other people, whether it's your MA, whether it's your community health worker, that are also touch points along the way in that conversation. Making sure that you're referring clients who are truly ready to engage in quit line services and that you're using that function of counseling to do so. Verifying that contact information is accurate and that it gets updated in the charts. Instituting a closed-loop tracking system so that on the clinical end, we really have an understanding of what happens and that we can be part of that system of following up with our clients and seeing how it went for them and making sure that clients really feel that their provider and their team is someone that they can rely on during this really hard time period when they're trying to quit. And what we will also realize is that just having this conversation is a win. Not everyone you have this conversation with is going to actually quit, but they are moving along that road of contemplation and moving to a place where they might be closer to making that decision to quit. Thank you.
Thank you, Sylvia and Deborah. And thank you, Scott. Yeah, that was great. I've definitely taken a couple of things away from this presentation. And we do have time for questions now. So if you haven't already, please chat in your questions. There were a couple of questions that came in, and one of them was knowing that people are sometimes concerned about how much extra time these new processes might take. What are you finding in terms of how much extra visit time do these conversations and these referrals, how much time is that taking your providers?
So the way that we've set it up, and we didn't go into great detail about the actual workflow, but we've split up some of the components of it so that part of it, the screening piece of it is on the medical assistant, and so that's time that is not on the provider. If someone does true counseling during the visit, that can take some time, and I'd say that could take, depending on the client and what stage of readiness that they're at, that could take anywhere from a couple of minutes to 5 minutes. And I think what we would recommend is if it looks like it's going to be a longer conversation, there are a couple of different routes you can go. One is to make the referral to the quit line, so the quit line really handles a lot of that counseling piece. Or we have also made the recommendation to have clients come back in for a visit that is targeted specifically to the tobacco counseling piece. Because it's true, it can take some time. The other piece that I'd say is that, we know from evidence and research that quitting tobacco is one of the most important things that someone can do related to all of their other chronic conditions and all of the different health issues that we see folks coming into the clinic for. So it does take more time, but it has a really wide effect, a really important and wide effect.
Okay, thank you. That's great. I think that clarified that person's question. There's another question here about whether or not it's required to use the online referral for the Oregon Quit Line, and how can someone's clinic get cards? I'm assuming maybe cards, quit line cards, yeah.
So the online referral tool is just one way of referring your patient to the quit line. As I mentioned, a provider can use a fax referral, they can use an online referral tool. If they can set up a e-referral within their EHR system, that's even better. At the minimum, they can pass out quitline cards with a number. And those resources can be found on smokefreeoregon.com. And when you send out these slides, I'll send you that information so you can include that if that wasn't included in the PowerPoint.
And this is Sylvia again. I should clarify that the referral that we're using at Multnomah County is a fax referral, and we have modified that a little bit. So we actually have put it as a letter in our EHR, so that some of the information on the client will self-populate, and then we print it out as a letter, and that's have the client sign it, and that's what gets faxed over to the quit line.
One thing I'd add too is we have quit line cards available in English, Spanish, and I wanted to say that maybe 4 to 5 other languages. So depending upon the clients that you're working with, we should have the language that they speak.
Okay, thank you. Another question, somebody was really interested in those screensavers you were talking about, Sylvia and Deborah, and they wanted to know, were those screensavers just something that your clinic created, or can they have access to those screensavers, or where do they find those?
Sure. So those are something that we developed in-house. You do need a special screensaver program in order to get those out on a variety of different devices, but it's a pretty inexpensive program. I think it's under $200. So we could certainly provide you with the images that you would put into that screensaver program. So if there are people that are interested, you can definitely contact me about that.
Great, thank you. I had a question, and maybe more for my personal interests, but I know there are several communities in Oregon and counties that have made smoking cessation a top priority in their community health improvement plans. And so I'm wondering, maybe Scott, if you have seen an uptick in folks using the quit line since these CHIPs and CHAWs have come out with those priorities?
Yeah, we track the quit line volume, and we see the largest increase in calls when we have a media campaign active. So as I mentioned on the webinar, there was a media campaign last winter. This went from middle December to around April, and during that period of time, depending on the month, there was about a 50% to about 125% increase in call volume. And then as we got away from April and we stopped putting advertisements on TV and billboards and online, we saw that there was still an increase in call volume from the previous year. There was I would say in May, June, July, there was still a larger call volume, although it declined. And then once we got to around August, it was more or less the same level as it was what we consider the baseline year, the previous year when there was no campaign. I've seen more interest with health plans, specifically CCOs, around cessation, now with the adoption of the tobacco prevalence use metric, which will go live in 2016. That was adopted by the Metrics and Scoring Committee this past July. And I've seen more interest with local partners, so local public health agencies and community-based organizations who are looking to support their clinics and their health plans around that metric. But as far as quit line volume, it seems to be really pretty much tied to our media campaigns. And then there's also a seasonal effect as well, I should add. So there typically is a larger amount of calls earlier in the year. A lot of people want to make a quit attempt after the New Year's in January. And for whatever reason, the middle of summer to late summer, we see the lowest call volume to the quit line.
And I can speak about it a little bit from an internal perspective. You know, at Multnomah County, when we were, prior to rolling this out, we did get some baseline data in, and we really had not been tracking the referrals prior to that. And we have made, since we rolled this out, and I haven't checked the data in a few months now, but we've made over 2,000 referrals. So that might not spike at all on the quit line's radar, but for us, that's a really big deal. And that's a lot of people in our system that, you know, we have gotten into some really needed services. So I think that, and it's interesting because we actually do try to plan some of these campaigns, such as the quit line screensavers. We do try to plan them around the first of the year. We know that's when people are thinking about these things, and we want them to have some tools to be able to act on what they're thinking on.
And we get a lot of great, let's add one more thing. We get a lot of really great data from Amir, our contractor, on the participants, and one of the interesting reports is how they heard about the quit line, so what motivated them to make the call. And typically the number one response is they were referred by their healthcare provider. When the media campaign was running, though, that was the number one response. About 2/3 of all the quit line participants mentioned that through an advertisement, they got the number, heard about the quit line, and made the call. But typically, outside the media campaign, it's the healthcare provider who is giving them that information.
Okay, great, thank you. There was another question that came in about whether or not the web address and fax number for referrals will be provided, and those are both in the slides, correct? And so we will be making the slides available after the webinar.
Yeah, they're both in the webinar. Just note that on the slide that mentions the online referral tool, the link isn't actually on that slide. It's on one of the previous slides where I mentioned that a participant can access service through the website. So it's quitnow.net/Oregon, and that's at the beginning of the slide deck.
Okay, thank you. And then finally, if there were 3 things that you'd like folks to take away from this call today, and maybe we can go through each person and just say 3 different things, what would those 3 takeaways be?
This is Scott. I would say just to have that conversation with the tobacco user. We know just asking them about tobacco use and then that follow-up advice or referral to service is huge in increase in cessation rates.
This is Deborah. I would say as well, the conversation, getting it started, and getting the message to everyone when they ask the question, what's in it for me? It's about everybody's well-being. If the provider's worried about their diabetes, smoking cessation is going to help that. And yeah, just getting the conversation started.
And this is Sylvia. Definitely agree about the conversation. And I think that conversation with the clients also needs to be a conversation at all levels of the organization that's trying to implement this. You can't do it unless there's buy-in from all levels of the organization. And this is something you can have fun with. We had a lot of fun creating those tobacco cessation screensavers, involving people in different ways. And I think the more that you can get people, we use the word buy-in a lot, but really it's getting people's heads and hearts involved with this work. If they care about it and they have a reason to be invested in it, then they're going to make it happen for their clients.
That's great. Words of wisdom from experts. Thank you so much. If there aren't any more questions, then I will say that people may feel free to email you, Deborah and Sylvia. Your emails are here on the slides.
Yes, definitely.
Okay, people think of things in the next day or so. So just a reminder that we will be sending out the webinar recording link along with the PowerPoint slides soon. But other than that, that is all we have for you this morning. And thank you, everyone, for being here early on a Wednesday. And thank you to our wonderful presenters, Scott, Sylvia, and Deborah. It's really been a pleasure.
Thank you.
Thank you.
All right, take care.